Good evening, everyone, and thank you for joining us for tonight's Woo You event with Dr. Jason Jedlicka. He will be talking on a comprehensive management of the patient with keratoconus. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So I'd like to introduce our amazing speaker tonight, Dr. Jason Jedlicka. He is a clinical professor at Indiana University School of Optometry and the director of the Cornea and Contact Lens Service. He is a diplomate in the American Academy of Optometry's Cornea, Contact Lens, and Refractive Technology section, a past president of the Scleral Lens Education Society, and a fellow and board member of the Contact Lens Society of America. He has contributed to multiple textbooks as an author on the topic of GP lenses, and he was awarded the GPLI Practitioner of the Year for 2021 and the Scleral Lens Education Society Scleral Practitioner of the Year of 2023. So we're so excited to hear from you tonight, and I will have you go ahead and take it away from here.
Thank you, Dr. Sorenzi, and thank you all for being here. I do have some financial disclosures to list. All right, and if you do have any questions beyond what our time tonight permits, I have my email address listed here. I will also list again at the end of the presentation. So our topic tonight is keratoconus, and we'll start off with just a quick definition. And this is great to be part of this series on managing keratoconus, both in terms of the disease, the vision, as well as the psychological aspects of the condition, which Dr. Sint talked about in our last presentation from this series. But keratoconus is, again, a progressive, non-inflammatory, bilateral, but usually asymmetric ectatic corneal disease. It's characterized by thinning and weakening that leads to corneal distortion. And of course, we know it can occur anywhere between the early teens or perhaps even younger in some cases to even much later in life. So what we'll cover in this section tonight particularly is how does keratoconus develop, or why? How do we properly detect and or diagnose it? How do we manage the disease aspect of keratoconus? Because a lot of the times when I see patients now that come to me with keratoconus, I'm talking to them about, hey, there's two aspects of this. There's how do we manage your disease, but how do we manage your vision as well? And so those are really two separate entities, and we need to take them both and deal with them to the full extent to give our patients the biggest benefit. So how does it develop? So this has been a topic of discussion over the years. Is it genetic? Is it environmental? And I think that there's evidence that there's a component to it on both sides. There's been plenty of studies which talk about identical twins with keratoconus. We see this increased risk of developing keratoconus in those who have first-degree relatives. Literally a 100-fold increase in some cases having a direct relative. And so again, there is some genetic testing available for keratoconus. It is there are so many potential genetic sources of the disease that the tests that are available now are helpful, but they are certainly not all encompassing, and not everyone's going to test positive for a genetic test for keratoconus. I mean, we know that it is also associated with numerous systemic and ocular disorders. At the same time, there is plenty of evidence to suggest that there's an environmental component to this. Those identical twins who both don't have keratoconus, for example, the itch, allergy, eye rubbing aspect that we know about. And I've certainly seen plenty of cases that I would look at an individual with keratoconus and think, this is clearly genetic. And another patient who I would look at and say, this is clearly the patient's environment has led to this and their behavior. And so I think at the end of the day, we have to recognize that keratoconus is multifactorial, that there certainly is a genetic aspect to it in many cases, and that's important. Because when we know we've got that first order relative with it, those patients are at a significantly increased risk. And we can't neglect checking them for it at early ages. We want to try to detect it as early as possible. We do this with so many conditions that you have an immediate relative with this disease, and the doctor's going to tell them, make sure you have your siblings or your children checked at an earlier age just to screen to try to catch it earlier to manage it. So there is a genetic aspect, and we have a role to play there. Even if you're not doing genetic testing, there's certainly screening tests that we can do to look for keratoconus at the very earliest stages, which we can be involved with and we should be involved with. Again, there's also the environmental aspect as well, though, and that leads us to educating our patients about the things that they can do or avoid doing, which can make their condition worse. And we can't neglect that either. So recognizing that keratoconus is going to fall somewhere on the spectrum, and it's not always, it's not going to fall on the spectrum in the same place on everybody. Some are going to be very heavily genetically linked, and some are going to be heavily environmentally linked, and everything in between. How do we diagnose it? Most of the cases of early keratoconus that are picked up are going to come from a patient coming in for a regular eye exam, and they are experiencing some blur. And in the process of testing, we're going to find an unusual prescription change, perhaps, or we're going to find, if we break out our retinoscope, which we should on everybody, right? We're going to see something irregular about their corneal reflex that's going to allow us to think, we've got to look further into this. You're probably not going to see slit lamp findings at the earliest stages. I hope not, because if you are seeing stria or scarring, it's way too late in the process for managing the disease at a proper point. So we're looking for it in the subtleties, the retinoscopic reflex, the unusual change in cylinder axis in a teenager. A teenager whose cylinder axis changes from axis 170 to 145 in 1 year. That's unusual, and so that should lead us to look for signs that keratoconus may be developing. And keratoconus, it used to be years ago, we said, 1 in 2,000 or some odd number. That was pretty rare, and most of us wouldn't see it that often. And we know that number isn't that anymore. It's probably more like 1 in a few hundred. And so the prevalence of keratoconus either is becoming more, or we're just getting better at detecting milder forms of it. And we have technology that allows us to do a better job of detecting it. And ultimately, that technology is the corneal topography and ideally corneal tomography, which is the best way to actually make the proper diagnosis. Again, the clinical findings, you're going to see a distorted reflex like we see in the first picture on the left. We may see that Fleischer ring, we may see the stria, scarring, or sometimes you can actually visualize the thinning with an optic section. These things, again, hopefully we're not seeing these as an initial presentation, right? We're seeing these on patients who have been diagnosed and managed for years, but we don't want these to be our presenting signs, because that means that this patient has gone way too long missing the diagnosis. So again, for a long time, corneal topography was the test that we had that probably gave us the best clue into whether a patient had keratoconus. And we were looking for this kind of typical inferior steepening, this little hot spot somewhere on the lower half of their map. We can talk about superior keratoconus. I don't think it actually really exists, but we could have that discussion another time. Ultimately, it seems as though keratoconus is almost exclusively on the inferior part of the cornea, and it's the steepening effect that we see with topography. And so if you're sitting here and you say, well, I don't have corneal tomography, but I have corneal topography, and what would I be looking for to detect keratoconus in a patient? Some of the important things are, again, steep central Ks. You know that. You see a patient who comes in whose K readings are in excess of 48, 49, 50 diopters. You have to think that's not really normal, and I should be suspicious. We also are looking for these asymmetric bow ties. You see in the pictures these 4 little diagrams on the upper right part of our slide, where we can see that the upper part of the astigmatic pattern is much smaller than the lower part, or vice versa. We can also see the 2 radial axes, the major meridians of the vertical and the superior vertical and inferior vertical meridians are offset. And typically by more than 20 degrees, that would be considered to be highly suspicious of keratoconus. So again, as you see these diagrams of these topographies where our major meridians of the topographies are not directly opposing each other, they're not mirror images, but the upper part is skewing to one side compared to the lower, that's suspicious, and that should be further investigated with more testing, pachymetry, and or again, corneal tomography if available. Most topographers do have screening indices available to help with the diagnosis. The problem with relying again on just corneal topography is it doesn't tell us anything about the corneal thickness. And you could say, well, I have a pachymeter for that. And I'd say that's fine. But there are a whole lot of patients with keratoconus in the earlier stages whose corneal pachymetry is still, quote unquote, relatively normal, 500 microns. The problem, so again, with topography, we don't get any information about thinning or thickness of the cornea, and certainly not the rate of thinning or thickening of the cornea across the surface. Corneal topography also doesn't tell us anything about the posterior corneal shape, and we'll talk about why that's critical in diagnosing keratoconus. And again, if a patient isn't looking directly into the target, your fixation point on your topographer, you can get erroneous data. You can get a map that looks unusual or wrong. And so you've got to be careful that the patient is always fixating in the proper location. So ultimately, while corneal topography is quite helpful in managing keratoconus, and it's kind of, in a lot of ways, it's been the standard of monitoring for change in keratoconus, it is not the most effective at the very earliest stages of keratoconus, and it's not always the most effective at making a completely definitive diagnosis as well in its more subtle stages. So yes, useful, not the best tool, but a very, very good tool nonetheless. So again, I've mentioned corneal tomography, and of course, corneal tomography is similar to topography, but instead of doing a reflection off the corneal surface and looking at curvature, we're actually using Scheimpflug imaging to take cross-sectional photographs of the anterior chamber of the eye, both anterior and posterior cornea, and then we're reconstructing that into a three-dimensional view of that cornea. And the benefit, of course, there is it's giving us true elevation data of both the anterior as well as the posterior cornea. It's giving us corneal thickness. It's also giving us corneal thickness over the entire surface of the cornea, as opposed to just a single point or a handful of points that we might use with a ultrasound pachymeter. So again, corneal tomography really is the best tool for detecting early keratoconus, as it really gives us all the relevant information that we need to make a proper diagnosis. The benefits of tomography is it does tell us about the thinning or thickness of the cornea. And ultimately, keratoconus is a disease of thinning. The thinning is the thing that occurs first. That is, without thinning, you can't diagnose keratoconus. So you've got to see thinning of the cornea as you're presenting finding, and without being able to measure the thickness of the cornea over a broad area of the cornea, you're not going to accurately know whether thinning is occurring. Again, corneal tomography tells us about posterior corneal shape, and ultimately that is the most important part. If you think about what is happening in keratoconus, the patient's cornea is thinning focally. And because the intraocular pressure inside the eye is greater than the extraocular or the external pressure of the atmosphere outside the eye, the cornea is always going to bow forward. That's why our corneas are not sunken into our eyeballs, right? So corneas are going to bow forward. So if we weaken the cornea and it's going to bow forward more in that place, then the most exaggerated area of surface change is going to be at the apex of the cone on the posterior of the cornea, not on the anterior. So the posterior cornea is the place where we should be looking for the earliest signs of keratoconus. Again, corneal pachymetry is critical. Keratoconus is a disease of thinning, and we've got patients who may walk in whose corneas are 480 microns, who maybe have some slightly unusual looking astigmatism. How do we know whether that is keratoconus or not? We may have another patient whose corneal pachymetry is 520, who also has that same unusual anterior posterior shape. How do we know that's keratoconus? Ultimately, what we're looking for is if you have focal thinning in an area of the cornea, that area of the cornea is going to be thinner in relationship to what it used to be before it started thinning. And so, as we all know, the cornea, is thicker toward the periphery and it's thinner in the center. When you've got focal thinning, you're going to see a change in the rate of thickness across that corneal surface in the area of focal thinning. And so what you'll see is this progressive change in thickness, and our instruments will show us the thickness of the cornea over the entire surface of the cornea. What we're looking for there are areas that indicate, hey, this cornea is thinned, but it's thinned focally in one area where this is outside the normal standard deviations of how thin it should be in this area relative to how thick it is out in the peripheral cornea. So this progression of pachymetry is also a critical part to our diagnosing of keratoconus. So at the end of the day, a proper diagnosis of keratoconus really requires, at the earliest stages, if we want to be detecting at its most early and accurate stages, it requires corneal tomography that gives us indications of an abnormal posterior greater than anterior corneal ectasia and a clinical non-inflammatory thinning that leads to an abnormal corneal thickness distribution. Okay, again, corneal thickness alone isn't an adequate measure of keratoconus. It's got to be an abnormal thickness distribution, meaning we have focal thinning, not generalized thinning. So based on that, I'm just going to throw up a few topographies here, and we can talk through some of these interesting cases. So the upper left picture here is a corneal topography, and we can see by looking at it that there is some inferior steepening. Is this keratoconus or is this not? I don't think you can tell by this map. The fact is that this scale of topography of the steepening is a pretty tight scale, and that area of kind of orange color is only a diopter to steeper than the surrounding tissue. And without any posterior corneal information, I can't say for a fact whether this patient would have keratoconus or not. Same picture below. This is another patient with a area of thinning or of steepening inferiorly. And you might look at that and say, well, that sure looks like it could be keratoconus. When we look at the rest of the map, then we look at the corneal thickness and we look at the profile of the front and posterior elevation maps, we can see that this patient does not have keratoconus. They just have something else that is causing an irregular steepening of the inferior cornea. We have to look further into this case, but we're not diagnosing keratoconus in this individual. Similar looking map in the center here to the last one we just looked at that wasn't keratoconus, but in this case, if we look at the front elevation on the bottom left compared to the back elevation on the lower right, we can see this patient does indeed have focal steepening, thinning, and it is greater on the posterior map than it is on the anterior. And so this patient almost assuredly does have keratoconus. Again, you'd look at this map and say, does this patient have keratoconus or not? Certainly just by the curvature map we see in the upper left, it doesn't really look like it. It's a little bit bottom heavy, but the axes aren't skewed. We look at the corneal thickness and we see it's in the 490 range. Well, that's a little bit thin. We look at our posterior float maps or our anterior and posterior elevation maps. And we can see, if you look, the area where the little dot is drawn just to the right of center, we see a value of about +3. On the back of that cornea, we see a value of about +7, +9. There's a little bit of back surface change that, along with the pachymetry of 490 and some of the other changes, is very suspicious. Now, the fact is, this is the patient's better eye. Their right eye clearly has keratoconus. So we know, in fact, this individual does have keratoconus. But even without knowing what was going on with the right eye, we should be very suspicious of that left eye. And again, if all you had was corneal topography and all you saw was the upper left picture, it would be very hard to make that diagnosis. But this is the type of patient, especially in a teenager, who really needs that consultation for something to arrest the development or progression of their condition. Again, here's another photo. We can see that this looks like a asymmetric bow tie. Maybe is this superior keratoconus? I thought you said it didn't exist. The reality is, if you look at the rest of the map, you can see this is absolutely not keratoconus. This is someone with scar tissue and trauma to their cornea. But again, just looking at the map without knowing more about the shape of both the front and back of the cornea in relationship to each other and the corneal thickness, it's hard to make that determination just off their anterior topography. And finally, I have a couple cases. These are both patients who are post-LASIK, actually, who both were referred in for contact lenses for post-LASIK ectasia. Post-LASIK ectasia is a corneal ectasia, and it's going to present and look a lot like keratoconus because it's got the same findings in terms of a greater elevation on the back than the front. And this patient, if you look at the hot spot inferiorly, we look at the upper right elevation map, we see some bowing forward, but we look at the back elevation, we see an exaggerated bowing forward in the same place. This patient does have a corneal ectasia post-LASIK. Whereas this patient has a similar inferior steepening, but if we go, and their corneal thickness is certainly thin enough at 425 to potentially be keratoconic. But if we look at their elevation of the front and back of the cornea, there is no indication whatsoever that this cornea is focally thinning. And therefore, from my criteria, I don't believe this patient has a corneal ectasia. They have some irregular healing, perhaps, from their LASIK procedure, but it's not a post-LASIK keratoconus case. And why is that important? Again, it's going to come down to if the patient does indeed have an ectatic disease where progression is likely, we need to talk to them about the things they can do to arrest the progression or development of that condition if possible. So management of keratoconus in 2023 starts with early detection because there are things we can do. And that patient who is 15 years old with keratoconus developed isn't destined for a corneal transplant when they're 50 years old any longer. So detecting it early and off and when possible with accurate tools. Once we've made an actual diagnosis, we've got to talk to our patients about slowing or halting that progression. And that is managing their habits and also providing them surgical intervention with corneal collagen cross-linking when it's appropriate. Beyond that, patients with keratoconus have vision problems. That's often the presenting symptom. So we've got to give them the vision correction that they need while doing no harm. And contact lenses can do harm. And surgical procedures to help vision can do harm when they're not offered and managed and fitted and proper patient selection. When those things aren't done right, some of our ways of correcting the vision can do harm, and we certainly want to avoid that. We need to monitor our patients for further progression. And it is possible, sometimes even when patients have had procedures done to slow or stop the progression, that slow progression can continue. And it's not unheard of that cross-linking needs to be repeated in some cases, in particular when patients have less or the non-approved FDA procedures. Some of our alternative procedures may not be as effective. And so we've still got to monitor those patients for progression. And then we have other surgical procedures, more invasive, like corneal transplant, when other treatments are inadequate. And I will say that when we consider the disease management versus the vision management, we've got to realize that corneal transplant really is about the vision management still, because we rarely are doing corneal transplant because the disease has progressed too far, although it can occur when the cornea is extremely thin. But most of the time we are doing it because the patient's reached a point that their vision is inadequate for function and they need intervention. So why early detection is crucial. It didn't used to be, 20 or 30 years ago. We diagnosed keratoconus mainly because then we could talk to the patient about what the future held for them and the day they would need a transplant, and here's your hard contact lenses to wear, et cetera. But now we have other ways to manage it, and we can slow or stop the progression. And so it's critical to catch it at the earliest stages. We also know keratoconus progresses much faster in younger individuals, so catching it earlier means managing it more appropriately earlier. And we detect it early by screening those family members like we talked about before. If you have a patient with keratoconus and they are at an age where they have children, I always mention it to them, do your children have any issues with their vision? And if they want to be screened, if you have a corneal tomographer or know some way that they can get tomography done, to offer to have that individual screened to look for the earliest signs. Also, patients with any monocular vision issues, it's always good to get some type of corneal shape information to look for it. So, there's this whole decision-making tree for keratoconus, and we're not going to go through all of this, but I just want to show you, kind of give you an overview of all the different steps along the way. as we work through this with our patients, depending upon where they fall in their development of their condition. So the first thing, of course, is we want to stop the progression. And, we talked about the environmental aspect, the behavioral aspects of keratoconus, and when it develops or when it progresses because of behavior, because of environment, those are things that hopefully we can do something about. So we've got to always educate our keratoconic patients not to rub their eyes. And they may say, well, gosh, it just feels so good and my eyes are so itchy all the time. Well, there are ways to manage that. I've got ocular allergies, and there are times when my eyes itch like crazy, but I have eye drops, and the drops work. If I put a drop in, 9 times out of 10, the itching goes away in 5 or 10 seconds. And on those rare occasions when it's so severe that a drop doesn't knock it out right away, I'll put another drop in 5 minutes later, and usually by then it knocks it out. So there are ways to manage this eye rubbing for our patients, and to give them recommendations for cool compresses, allergy drops, whatever anti-itch drops. Just say, hey, just whatever you do, just don't rub your eyes. You can't do that anymore. You're running the risk of making your condition worse. Once patients understand that, I think that's a big first step in reducing the risk of progression that they might be causing to themselves. And then, of course, we have corneal collagen cross-linking, which is FDA approved here and everywhere in the world now. It really is the gold standard for managing keratoconus to reduce the risk of progression. And again, it's got to be talked about with every single patient with keratoconus. There are some patients where it is more critical that they get it done, and they get it done soon, and other patients that it is less critical. But it needs to be talked to everybody. Everybody needs this discussion about what corneal collagen cross-linking is. You may have a patient who is at an age where you feel like their risk is not that great. And that's fine, but that's not really your decision whether they should or shouldn't go forward with having it done. They may say, I understand, doc, that, from what you've said, my risk of it progressing isn't that great, but I'm going to sleep better if I have it done. And that's up to the patient then. So we talk to everybody about it. And again, for the younger patients with the already obvious signs of keratoconus, we need to get them into the system and into that process rather urgently. Other patients, we can have a little bit more of a time and a discussion. If they want to wait and monitor, there may be other patients as we get older that can wait. Again, age is a big factor in keratoconus development and progression. The younger the patient, the more that cross-linking becomes a matter of some urgency. As we get older, that's not to say it shouldn't or can't be done, but you may have a little more time for the patient to think about it and watch their condition over time and look for signs of progression. There's also been studies that show that pregnancy or delivering a child is a big factor for progression of keratoconus. So, again, for those younger women who may be looking to have children who have keratoconus, another strong recommendation that they consider having cross-linking done prior to having children. So again, there is a procedure, how cross-linking is done. There are many ways of doing it out there. There's only one FDA approved way of doing it out there. And from my perspective, I think it's critical that we talk to patients about the FDA approved procedure and why that is preferred in general. And that's because there is a lot of data. It's been studied in depth. The outcomes are well documented. The risk factors are well studied. And so when we talk to patients about what cross-linking is, you're going to be talking to your patients about cross-linking, giving them information about the FDA-approved procedure to then refer them out to have it done by someone who's not doing an FDA-approved procedure. You're misquoting data if you're giving them FDA-approved data. Okay, so I just want you to be careful to consider all your options and make sure that when we talk to patients about cross-linking, recognize that the safety profiles and the efficacy profiles are all based on the FDA-approved procedure. And so, again, that's what we like to recommend for our patients. The first step in the procedure is, of course, removal of epithelium. That can be uncomfortable, having the epithelium removed, but ultimately it's going to provide the best long-term outcomes for their disease management. And that's ultimately what this is about. Step 2 is to soak that cornea with the riboflavin solution for 30 minutes. Check and make sure that we have full penetration of the riboflavin into the anterior chamber. Check the corneal thickness and make sure we're at 400 microns or above. If it's below 400 microns, there is a hyperosmotic formula that can be used, or hypoosmotic, formula that can be used to then swell the cornea, and you can monitor. And as you instill this hypoosmotic formulation of riboflavin, every now and then, every few minutes, we're going to double check that pachymetry. And once we hit 400, then we know that we're safe to proceed. So again, once we know we've got at least 400 microns of corneal thickness, we then apply the UV light of the very specific wavelength to the eye for 30 minutes as we continue to apply the riboflavin solution during the treatment time. Again, I think it's important to talk to patients about what cross-linking is. It is really just to strengthen the cornea, to increase the bonds between the fibers of their cornea, to strengthen it and make it less prone to stretching and bowing and continued thinning. It is not a refractive procedure. The goal is not to improve their keratoconus. It's to stabilize it where it is. Now, does it improve? Yes, in many cases it does, and that's a wonderful benefit, but it is not something that we want to guarantee or promise our patients is going to happen. And that when they've healed up at a certain point, within a few weeks or so, a month, they're going to need to have some updates to their correction for vision. And we have to educate them again that their vision is going to change over the several months afterwards. And it may require more than one adjustment to their glasses, contact lenses, whatever their vision correction of choice is. The best candidates for cross-linking are going to be our patients who we know have progression of ectasia because we know that there's a progressive condition going on. Those patients who have little or no scarring is a better candidate than those who have more scarring. That patient who has a minimum corneal thickness, preferably 400 or above, but in the cases between 300 and 400, the ability to swell the cornea is helpful. And then again, that they've got vision and function worth saving. If the patient's already at a point where even with their best contact lens correction, they're 20/50 or 20/60, the horse may have left the barn already. So it's at those points, maybe this isn't the time to do that. One last thing I think is important to mention to our cross-linking patients, and that is that I tell all of them that when you have the procedure done and as you heal, you are probably going to feel those first 2, 3, 4, 5 weeks that your vision maybe has actually gotten worse in the eye that you've had cross-linked. And that actually is borne out in the FDA studies on cross-linking. The patients actually were a little worse off at the 1-month point, and that could probably be attributed to the process of the epithelial healing after debridement and so forth. But that by the 3-month point, the patients were better and they continued to get better. So I've had patients who sat there at 1 month and said, yeah, I feel like things are worse. I'm glad you told me to expect this because I might be nervous otherwise. So it's something to mention to patients, not to scare them away, but to just make them aware that, it could get a little bit worse before it gets better. But ultimately, you should bounce back to where you are now or maybe a little better in the long run. So before we get into the vision correction part, just to kind of wrap this up, again, we talk to our patients with keratoconus. We say, I'm going to manage your disease and I'm going to manage your vision. And managing your disease means don't rub your eyes. And if you need things from me to help you with that, let me know and I'll give you what I can give you to help reduce the itching or whatever the urge is to rub your eyes. And the next part of that is to stop or reduce the risk of progression. And that's the cross-linking. And that's where we also need to have that discussion. That is managing their disease. That is part 1 of managing that keratoconic patient. Part 2 then is giving them the vision they need to function in daily life. And that's going to be different depending on the patient. I have a probably 5% of my keratoconus patients, maybe even a little more, maybe 5 to 10%, are functioning just fine with glasses. And they're completely happy in their glasses. And their vision is 20/20 minus 2 in one eye and 20/25 minus 1 in the other eye. And they're absolutely happy that with their vision. And we've discussed cross-linking, we've discussed no rubbing your eyes. How are you doing with your glasses? Oh, I'm fine, and my vision's good. Well, then let's just keep with your glasses. So it's glasses are not a bad thing. You can have your glasses can be UV coated and keep UV off the corneas. They're less traumatic to the cornea. You don't have rubbing issues. You don't have people that when they pull their contacts out, they want to rub their eyes. And so in some ways, you could say that spectacles have benefits over contact lenses for those patients who are satisfied with them. So I'm never one to push a patient to get contact lenses if they're happy with spectacle correction. Soft lenses can also be used for managing keratoconus for some of our patients. And because we have another episode of this series on October 18th coming up with Dr. Susan Resnick, she's going to talk to you more about utilizing soft lenses for keratoconus. So I will defer to Dr. Resnick to talk more about soft lenses at our next installment. And a couple weeks later, Dr. Brooke Messer is going to talk also more about keratoconus, which lens design works best. And she's going to talk more about the GP options like corneal GPs, hybrids, piggybacking, and sclerals. And so she'll go into more depth about that. I'm not going to spend any time tonight talking about this other than to say that I think, and it's just my opinion, and I'll be a little controversial here, and I'm happy to have people disagree with me, but I think as time goes by, I'm increasingly convinced that I have a hard time justifying fitting keratoconus patients with corneal GPs because we know that we just talked about not rubbing the eyes. And we talked about all these things that we can do behaviorally, environmentally to reduce the risk of progression. Then we put them in a lens that rubs on their cornea all day. Every time they blink, it rocks back and forth on their apex or on the surrounding tissue. And I know a scleral lens isn't going to do that. I know a scleral lens is going to vault over the whole thing, and I don't have that. So I'm just saying that we've got to not be afraid to look at our habits and say, just because we've always done it this way, is that really the best way to do it? And consider, should we be changing our thinking about how we fit our patients with keratoconus with contact lenses? And one of the other benefits, of course, of scleral lenses is we've got the great option of adding HOA correcting optics to our lenses now. And that's going to be brought out probably a couple weeks after Dr. Messer, when Dr. Gelles and Dr. Morrison talk to you about scleral lenses for keratoconus. So just a little teaser for the upcoming episodes where we'll go into a lot more of the contact lens and vision management of keratoconus. Well, what about when contact lenses don't work well? What else can we do? Corneal rings, such as Ferrara rings or Intacs, are another option. And they've gotten a bad rap, and in some ways justifiably so, but it wasn't really the rings that were the problem. It was the surgeons implanting them weren't always doing the best patient selection, and they weren't really giving the patients the best information about what the procedure would and would not do for them. Ultimately, I think corneal rings work great in a very specific subset of keratoconus patients. And those are patients who, when we measure their visual acuity through a GP lens and you look at their cornea, there's no scarring there and their keratoconus isn't even really that bad. Maybe it's mild to moderate. And yet you put a GP on them and they're only getting 20/30. And you think, why on earth are you only 20/30? And we know now that it's a lot of their higher order aberrations. It's the coma and things like that come along with keratoconus that the lens isn't correcting. Those patients actually do really well with corneal rings because it will work to the posterior corneal surface issues where a GP on the surface of the cornea isn't going to do anything to address the posterior cornea. Well, corneal rings do address the posterior cornea. They change the shape of the posterior cornea, and patients who have posterior corneal wavefront issues like coma, corneal rings can resolve some of that coma. And I've had many patients who, after corneal rings, were able to get 20/20 with a GP lens again. So that's one case. And then another case is those patients who are mildly myopic, uncorrected. And you think, well, who cares? Who cares? Well, our keratoconus patients wear their lens. Some of them wear their lenses 16 hours a day, 7 days a week, right? Because they can't wear glasses, because they can't see out of them. So, hey, if I can give them corneal rings, and with those rings, I can improve their best corrected by a couple lines, and maybe they're uncorrected by several lines, Maybe they don't need to wear their contacts quite as much. Maybe they can get home at night and pop their lenses out and function without any correction around the house a little bit. I think then that's a consideration. There's no reason to suspect that corneal rings do anything to slow or stop progression. So telling the patient that it's going to help their disease not be so severe or it's going to help slow down the progression is not correct. Another thing that we can consider doing for our patients surgically to improve vision is corneal cross-linking along with topo-guided PRK. So ultimately what we're doing here is we're doing a custom PRK treatment to smooth the corneal shape irregularities. This is not to reduce myopia. This is not to flatten the cornea where it's already thin necessarily. It's to regularize the surface. And the goal is to not remove more than 50 microns of tissue when it's done. There's two different versions of this. There's the sequential TGPRK, which is you do cross-linking, you allow the cornea to stabilize after a year or two, and then you do the topo-guided PRK at that point. The other way to do it is simultaneous, where you literally do topo-guided PRK first, and then you follow it up with a corneal cross-linking treatment at the same time. And interestingly enough, contrary to what seems like common sense or what I would expect, the results so far have shown that simultaneous procedures get better outcomes. And I don't know why, to be perfectly honest, but that's just what the data has shown. So my gut feeling about this is that it looks promising. The data looks good. If you look at this patient here, we've got a picture A on the upper left, which shows pre-topo-guided PRK with cross-linking, and B, the lower picture, which shows afterwards. Obviously, if you look at the top left picture, which is their anterior corneal curvature, you see it's dramatically better. So in this case, you'd have to say, well, this certainly looks like a great thing for our patients, this cross-linking with topo-guided PRK. It's really improved things. The problem is, if you actually look at the posterior elevation map, so this would be the bottom right picture of the 4-in-1 display. If you look up at A, the pre-treatment, and B, the post-treatment, our posterior elevation in the apex of the cone has actually gotten worse. And so we're seeing quote unquote possible progression of their keratoconus, even as the front surface of the cornea looks better. So it makes me a little nervous. The data is still coming out. There's still more and more cases. And I think we need to see in the long run, is this going to be something where 5 or 10 or 15 years down the road, these patients continue to show not only improvement, but stable improvement, and that the progression isn't returning even in the face of cross-linking because we've thinned the cornea even more. All right, well, just wrapping up here with a last section on corneal transplants, and just to mention the options, that we still have penetrating keratoplasty. The number of penetrating keratoplasties being done these days is the lowest it's been in decades, and that's partly because of lamellar grafts, and it's partly because of corneal collagen cross-linking, keeping patients from needing this. Penetrating keratoplasty, of course, is when we transplant the entire central cornea, 6 to 9 millimeters, usually somewhere around 7 is typical, depending upon where the apex of the cone is and how expansive the cone is. Of course, the risk here is the irregularity and the risk of side effects like glaucoma, cataracts, rejection. So another procedure which can be useful is deep anterior lamellar keratoplasty, or DALK. And this is a procedure which was pretty much reserved for third world countries where corneal storage and preservation was lacking. And so patients, you could use inferior grade graft tissue, donor tissue, and function. But just in the last few years, even in the US, this is growing in popularity as our corneal surgeons' skill grows and their ability to get the cornea stripped all the way down to Descemet's membrane and not leave any stroma behind. As that gets better, we get better outcomes. The problem with DELC always was when you left behind a little bit of stroma and then you took a donor tissue where you had stroma touching the stroma, you create a refractive interface. And that created a lot of issues with diplopia and things like that after a DALC. If you can bear the anterior cornea, get it all the way down to Descemet's membrane, and then put the donor tissue on, you're going to get good visual outcomes. And I've seen some DALC procedures in the last few years where patients are getting 20/20 quality vision without those issues that we would have seen 10 years ago. So again, this is really comes down to getting down to Descemet's membrane. As far down as you can get, the better. The risk, of course, is if you get too far and you perforate, you've got to be prepared to do a full penetrating keratoplasty, which means you still need to have good quality donor tissue available to you, even if you're going to plan to do a DALC. There are a couple other surgical interventions that are sometimes used in our keratoconus patients. Some doctors will do implantable Collagen lenses or ICLs, and this is to reduce the highly myopic prescription that a lot of our cone patients have, and so that they don't need to be as dependent on corrective lenses to function. IOLs can also be used for our patients with cataracts, and they are helpful just like in any patient, although they can be difficult to get a good IOL power sometimes. And toric IOLs, unfortunately, are used for some of our keratoconic patients, although I wish they weren't. And so we always have to understand that when we've got a patient with keratoconus who's had cataract surgery, and we put a GP lens on them and our overfraction yields 2.5 diopters of cylinder, we've got a toric IOL. And so again, sometimes toric IOLs can be helpful, especially in our milder cone patients and those patients who've had cross-linking to stabilize things. But in the patient with a moderate to advanced case, they can be quite troublesome. So again, managing keratoconus in 2023, contact lenses notwithstanding, because you're going to tune in for the next 3 episodes to find out all about those. Let me just urge you to do your best to detect early and properly. If you don't have access to a corneal tomographer, know somebody in your area who does. And if you do have one, please be willing to do these tests for your colleagues who don't have one. Look for the earliest signs again in those kids, the younger, the teenagers, for example, with subtle refractive changes that don't follow normal tendencies, not like just a normal myopic shift, but cylinder changes and things like that. Break out your retinoscope and look at the patient's reflex if you're suspicious. And then once we know that we've got keratoconus that's been detected, again, we want to manage their eye rubbing tendencies, their itching their eyes tendencies, refer for cross-linking, manage their vision with proper corrective lenses, depending upon where they're at with their stage. Do no harm. Consider corneal rings or HOA correcting sclerals when their best corrected VA is reduced and the cornea otherwise looks unscarred. And then when all other options are exhausted and the cornea is scarred, corneal transplant is an option, though again, it really should be safe for those patients when the cornea or the vision's not manageable with a rigid lens, because most of our graft patients will end up being back there anyway in the end.